So it's .6 and a very good evening to all of you present here. On behalf of IAPSM West Bengal Chapter, I, Dr. Aditi Aikad, Secretary IAPSM West Bengal Chapter, feel deeply privileged and honored to extend a warm welcome to the esteemed speakers of the day, the dignitaries, the national body officials, our state president, and all the delegates who have chosen to spend this evening learning with all of us and being a part of the inaugural webinar of this webinar series launched by IAPSM West Bengal Chapter in association with National IAPSM. The response has been overwhelming, and it goes on to show that we all believe in the shared commitment of learning, preparedness, and service to the community. Well, today's topic is Ebola. Now, many of you might ask, why Ebola for an inaugural webinar? When it is sitting pretty within the geographical confines of Democratic Republic of Congo and Uganda, and just a stray case in France. Why this? Is it out of panic? Or is it out of publicity? No, my dear friends, it is neither. As we welcome all, it is because of preparedness. COVID has taught us the virus spread very fast, and so does misinformation and fear among the people. But what needs to go faster is our collaboration and preparedness. And that is precisely the reason why we have gathered here for this webinar. As we take on this venture, I believe after these deliberations from our eminent speakers, we will be not only informed, but better prepared for a more resilient tomorrow. And for that, I profusely thank our esteemed speaker of the day, Dr. Pavana Murthy from SEARO WHO, Dr. Amitav Sarkar, ex-WHO, and moderator of the day, Dr. Preetam Roy, again from WHO, entity coordinator, who will take us through the proceedings. And also, a heartfelt thanks to the National IAPSM for giving us all the support and encouragement. We are having our President-elect, Dr. Pradeep Kumar Sir, also with us. And we once again thank each one of you for making this inaugural journey so memorable. With that, I hand over the proceedings to Dr. Preetam Roy, WHO Entity Coordinator, Managing Editor of IGPH, and Academic Editor of Clause 1, and a wonderful orator himself. So over to Dr. Preetam, and once again, my heartfelt thanks to each one of you. Dr. Preetam, please.
Thank you, ma'am. I think it's a pleasure and honor for being part as a moderator of the first webinar series.
Dr. Preetam, can we have the sound a little louder?
So it's a really pleasure. And thank you, ma'am, for being hosting and being part as a moderator for the first webinar series of IAPSM West Bengal. So good evening. to all the national and the state office bearers of IAPSM, distinguished faculty, colleagues, esteemed participants, and members. It is my privilege to welcome you in this important scientific session titled Ebola at the Crossroads, Emerging Risk, Hard-Won Lessons, and Future Readiness. Few infectious diseases have challenged the global public health as profoundly as Ebola virus diseases. Beyond its exceptionally high case fatality rate, Ebola has repeatedly and reportedly exposed vulnerabilities in health system, highlighted the consequence of delayed detection, and demonstrated how rapid localized outbreaks can become an international public health emergency in our connected world. The recent outbreaks in Africa reminds us that Ebola remains an evolving threat. Increasing human-animal interaction, ecological changes, the population mobility, the urbanization, and the humanitarian crisis and the fragile health system continue to create conditions favorable for the emergence and re-emergence of zoonotic diseases. Yet, the Ebola story is not solely one of crisis. It is also one of the remarkable scientific progress. Over the past decade, we have witnessed transformative advances in rapid molecular diagnostic, genomic surveillance, ring vaccination strategies, monoclonal antibodies, therapies, infection prevention and control, community engagement, and international coordination under the international health regulation. These hard-earned lessons have strengthened not only the Ebola preparedness but also the global response to the subsequent health emergencies, including COVID-19. Today's discussion, therefore, goes beyond Ebola itself. It is fundamentally about preparedness. It is about strengthening surveillance systems capable of early detection, building resilient health systems, investing in frontline health workers' capacity, integrating One Health approach, and combating misinformation through effective risk communication and ensuring equitable access to diagnostic, vaccine, therapeutics, and critical care, which as a WHO we care for. As a moderator, our objective is not merely to revisit the past outbreaks, but critically examine what has worked, identify the persistent gaps, and explore how global health community can translate evidence into a sustainable preparation for the next epidemic. I encourage everyone to actively engage with our distinguished speakers, ask questions, and share your perspectives that will enrich this dialogue and that will ultimately fulfill the whole purpose of organizing the webinar. So I am really thankful to the IAPSM West Bengal chapter for hosting such an webinar on a timely point this. And with that, it is my great pleasure to invite our first speaker, Dr. Pavana Murthy from WHO Southeast Asia Regional Office. Dr. Pavana Murthy is a public health expert specializing in epidemiology and health information management. He has led both national and international initiatives focused on disease surveillance, outbreak response, and health system strengthening. He supported India's integrated disease surveillance program. He developed the near real-time electronic public health surveillance system through IHIP and the health management information system 2, which is operational across all the states in India. He received the prestigious DG Team Award for IHIP. He presently works with us in the SEARO WHO as epidemiologist, surveillance and alert team, and the WHO Health Emergencies Program. So it's our pleasure, sir, for being with us, and we would like to hear from you. Thank you, sir.
Thank you, Roy, and thank you, Dr. Aditi, for the introduction. So I will take you through a few slides. Let me just share some slides. Can you see my screen now?
Yes, sir, it's visible, sir. Please continue.
Just give me a
See if the
minute.
audio could be little louder.
Just give me a minute. uh, Yeah, so is my voice clearer now? Yeah, so let me just take you through some brief slides. So let me just start. This is the Ebola, which is called the Bundibugyo virus disease, and what we are seeing is number of cases, and if you see the cumulative number as of 12th of July, it's like 1,873 cumulative confirmed cases, and there are three epicenter provinces. And we are just comparing a time of few days, like 10 or 15 days, 29th June. And from 29th of June, what we are seeing is an increase of like 540 cases. That's 40.5% increase in the last 10 days. So the Ebola outbreak is actually not over. And if you see the deaths among the confirmed cases, there are nearly about 672 deaths, and the case fatality rate now is 35.9. When we actually started in the first few weeks of the outbreak, the case fatality rate was 14%. From 14%, slowly it has now increased to 25%, and now it is like nearly 36%. So there is actually, from the last 29th of June, there is an increase of 273%. That is a 6 point increase in the case fatality rate. Then the patients in isolation, the bed occupancy has also increased to nearly about 154 since the last 29th of June, which is nearly about 2.4 points increase since the last 10 days. So it is not like it's coming down. So there are still a lot of cases getting detected, deaths being reported, and also cases being confirmed. Cumulative recoveries, there are 306, which have also increased since last 29th June, 217, which is 61.9%. And then suspected cases today is like 91 deaths as of 12th of July, and totally 299 suspected cases. This is the daily figure that we are actually counting. And among the contact follow-up rate, both in Ituru and North Kivu, it is 71.7%. So the contact follow-up rate has been pretty low, and in fact, it should be nearly touching 100% or 95 or and above percent. So if we are not able to do the contact follow-up, then I think again we are not achieving. So some of the key highlights in the past, say like 24 hours from 12th of July, we had 43 new confirmed cases and 26 deaths, especially coming from Ituru and North Kivu. The epidemic has spread also to Hot Ili and Chapo, expanding the provinces to 5 provinces, including earlier it was just 5 provinces which were involved. Now coming to this uh, the trend that we see is usually, if you see, like we just said, like 1,873 cases, 672 hospitalized, occupancy is like 95%, cumulative recovery is 306, and contact follow-up rate is actually reduced. In 29th of June, it was 82%. Now contact follow-up rate is still like 71.7%. In 29th of June, there were 3 provinces, that is total 35 of 104 provinces. Right now it's 41 out of 140 provinces, and 5 provinces are affected. That's more increased to 2 provinces since the last 29th of June. So this is what we see right now. So just to take a breath back, this did not start thing. It actually started some time back, even in April. It was an index case that was first suspected case, and then between 27th to 28th of April, there was a death of the first suspected case. The symptoms were actually consistent with the viral hemorrhagic fever. And in 14th of May, there were samples that were sent. 8 out of 13 samples were actually positive. And initially, it was not positive because this is a new virus. It's called the Bundibugyo virus. It did not get detected through the usual genomic sequencing methods. So it had to have a real-time PCR, which is specific. And then it took some time for us to actually detect this new virus. So 15th of May, there was a sequencing, and this Bundibugyo strain was officially declared as the 17th epidemic. Then between the 17th to 18th, we had a PHEIC, which was declared by WHO Africa. And also, you see the update of cases as we see 1,333 cases in 3 provinces, and now we see 1,873 cases from 5 provinces. That is 41 of 140 health zones are affected. So there is a persistent risk factor. Basically, it is the population movements which are there between the provinces and between the Uganda. There's also insecurity, there is antisocial, there is mining activity. There are also cross-border exchanges between Uganda and also between South Sudan. So if you see some of the areas here, the areas in pink, which is maximum affected, is the Ituru, which is here. On the right side, you see, then you have the North Kivu and the South Kivu. And then you have the border, which is slightly highlighted in blue, which is the infiltration into the Uganda side of the Uganda side. So in Ituru, we see that this is the epicenter, and it contains 91% of the cases so far. So here we have like 21 of 25 out of 36 health zones. That is nearly 69% affected in Ituru district. In North Kivu, we have 11 of the 34 health zones, which is 32% affected, but it has the highest case fatality rate, which is nearly about 57%. Then we have some of the other provinces which were affected. The South Kivu, of course, earlier was affected. Now we have the Shopo, which is the newly integrated since 29th of June, which has nearly about 13% of the health zones affected. Then you have the Hot Ulele, which is one of the health zones affected, that is 7.7%. And in South Kivu, we had in 42 days we had no new case, but right now we have like there's one out of the 34 health zones affected, which is 2.9%. So if you see the weekly trends, what you're seeing here is, of course, this is little bit in French here, but you can see the trend lines. This is the weekly cases of cases then death, which is happening especially in DRC. And you can see that, of course, in the last week of 26, we see a drop, but we still need to wait because there are still confirmations and other things. So data is still not complete, but we do see that it is completely an increasing trend for both suspected cases and as well as deaths which are occurring in the DRC region. The new cases in the last 24 hours, especially in thing, was 43. Then new deaths were 24, and alerts that are getting managed is nearly about 1,516 alerts, and only about like 84% of the alerts are getting investigated. So if you see the confirmed cases and deaths by province, you see the Ituru, which has 1,705 confirmed deaths, 577, and the case fatality is 33.8%. And new cases in the last 24 hours is 42. So the Ituru province is still the highest affected area and maximum number of health zones which are affected in this particular area. Then we have the next one, which is the North Kivu, which is the maximum of 165 cases and nearly 94 death. And the case fatality rate here is like 57%, where we have 11 out of 34 health zones which are affected. The new cases in the last 24 hours is one case. So we see that mostly it is the Ituru. And between the South Kivu, Haut-Uele, and Shepo, we see that cases and death are low. And we also see that there are no cases in the last 24 hours. So just to consider the whole aspect, the total CFR is like now 35.9%, and 41 out of 140 health zones are affected. And the new cases in the last 24 hours is like 43 cases. The epidemic concentration is like Ituru alone accounts for nearly 91% of the cases and 85.9% of deaths, which is like 577. Most affected zones are the Bunia, Rampara, Mongbalu, Nizi, and Nankudu. So these are the five most affected zones, which account for nearly about 83.5% of the provincial cases. North Kivu has the highest crude fatality rate of 57%. This is usually driven by the Katwa, Beni, and Butembo regions in that particular North Kivu. So the key actions that are actually taken is there are various pillars. Of course, there is coordination, and usually there is this. Recently, there's inauguration of the Ebola treatment centers extension, especially in Bunia General Hospital and Kingzo by the Ministry of Health. And epidemiological surveillance, there are alerts which are coming in on a daily basis and they're getting managed. And approximately about 84% of the alerts are being managed on a daily basis. And 299 suspect cases are being validated. On the laboratory side, uh, nearly 236 samples are tested, especially in Ituru and North Kivu, with a 23.7% positivity rate, especially in Ituru. Infection prevention control is the biggest hurdle, where especially in these the providers of the patients and also the households. 29 of 31 households were decontaminated in Ituru, and nearly about 488 providers were briefed in North Kivu in the recent days. Regarding the case management in the recent days, there are 110 admissions, 6 recoveries, and nearly 981 hot meals being served to patients. And and in the logistics side, nearly about 200 blood units were delivered to Bunia. 42 motorbikes were handed over, especially to North Kivu. There's risk communication reaching nearly about 11,000, nearly about 12,000 people. and 58 rumor feedbacks are being addressed, and the security issues are there definitely, and Awakubi checkpoint was vandalized, and also there are awareness activities that continue in Ituru. So these are some of the recent key actions of response by pillars that are actually taking place in the Africa, especially in DRC and Uganda. Now here you see the alert management and contact tracing, and you see in the last 24 hours between the various alerts between Ituru, totally like if you see new alerts with 1,497, alerts investigated were 1,285, investigation rate was 84%, and suspected cases validated were 299. In the contact tracing, you can see that contact tracing is better in North Kivu, which is nearly about 89.7%, but the worst affected province, Ituru, has the lowest follow-up of contact tracing, which is 68.1%. And it is very low, and I think this is also a critical issue that needs to be resolved in the coming days with better contact tracing and follow-up. Total from both Ituru and North Kivu, total is about 71.7%. Target we are looking at is more than 95%. And on 29th of June, it was like 82%. Now it has actually dropped a little bit with the contact tracing. Regarding the point of entry and the control points, nearly about 164,866 travelers were screened. That was nearly about 94.6%. And also the point of entry and point of was activated with nearly about 100% coverage. Recently, 2 dead bodies were intercepted as of 12th of July, and especially North Kivu. Some of the key challenges and required actions, we see that the bed occupancy is very high, especially in North Kivu, reaching to nearly about 135%, and there is a risk of nosocomial transmission. So there is a definite need to accelerate the Ebola treatment center expansion and deploy temporary structures. Regarding the contact follow-up and below target, it's like 71.7% and requires strengthening, and also for community workers to incentivize and also to get them more involved into this contact tracing. Regarding the reluctance towards post-mortem, there is delayed confirmation and also the case under assertment. So there is a need to intensify community engagement and involve some of the local leaders. So this is a critical area which also requires action to control the Ebola disease. There's also a funding gap, nearly about 20 million USD shortfall, limiting the full implementation of the response. There's an urgent need for resource mobilization and advocacy with partners. And insecurity and limited access is the key one, and there are armed groups activity restricting access, especially in the high-risk areas. So there's a key need for action to strengthen the security coordination and some of the humanitarian access in these particular areas. Coming back to our region, we have the public health and social measures in our own SEARO region. And you can see that we have some of the isolation and quarantine documented. We see that it is there in Bhutan, India, and then we have something from Thailand. Of course, we see like in Bhutan, we have facility quarantine, home quarantine, especially people who are coming from South Sudan, non-resident options for facility. This is actually from the Royal Ministry of Health Travel Advisory, and the duration is mostly 21 days. For India, it is like home quarantine, especially people who are coming in if any suspected case. Major entry screening are being done at the major airports, and now it is actually online screening, which also they have to fill in a card, especially if they're coming from these particular countries. We are also getting this information from the media, various media sources, and also from the IHR communication. In Nepal also there is entry screening and also documented quarantine protocols under review. Especially we are looking at this from the various media sources. And for the Thailand also, we have from official and media sources, there's also the facility quarantine, and entry screening has been there. This is actually a Ministry of Health officials uh, order that we have noted. So this both from official and media sources that we are there. So these are the few countries that have taken steps, but actually no particular risk. The risk in these countries is low, but we still need to be on the guard because this is a new strain, BBD. We also have cases who have been in DRC and also contacted the disease. There's one case in France. We also have one recent case in US which was detected. And some of these cases are now being treated also in Germany. So we are getting cases outside of DRC, Uganda, and the first case is also detected in France. So this is the other update. And I think that's the overall situation that I want, but there are a lot of references here, since I will keep it short for now. If there are any questions, then I can take it from there. So let me hand this back to the organizers.
Thank you, sir, for quickly bringing us an overview and also giving a very good, not only the current scenario in the African region, but the Southeast Asia context, especially India, and also in other parts. And I think the most important is the infection prevention and control, which we also found while dealing with Nipah in West Bengal, and you were also closely associated. So this infection prevention and control part needs actually a very good discussion, and also contact tracing, I think, which was lacking. So these are very important. So sir, before we move to the next speaker, I just request you, if you just highlight that what from the preparation point of view, like a few lines about infection prevention control and contact tracing, what is lacking there and what can be actually done to get that targeted approach.
I think definitely the key issue is I think the high bed occupancy rate. So we are having a number of patients. There are no beds. So and people are crowded, and I think the contact with the health workers is the key issue. Many health workers have also been affected in this thing. So the health workers who come into contact are the highest risk. I think they need to be really equipped with equipments, with all the infection prevention and control, um, whether it is PPE, whether it's gowns, whether it is things. That is number one. And also, if they can, the patients wise, segregate them so that, or expand the Ebola treatment centers. I think that's the talks that are going on to increase the treatment centers to disperse the patients so that, patients can be controlled thing. So I think the nosocomial infection is a key issue here, which we need to control. And one let down or any let guard, when you remove the guard, I think there's a high risk of infection with this virus. So I think that's pretty important as part of the IPC that we are looking at.
Sir, please
Can you
unmute.
get?
Sir, please unmute.
There is another pertinent question that given the increasing human-wildlife interaction, climate change, migration, and fragile health system, should countries move from a disease-specific preparedness to a unified pathogen X readiness index? Will that help? And what can be the indicators to predict the vulnerability of any geographic area like districts in India or so? If you like to comment on that.
I think specific to India, I think that we need to be vigilant, and I think the issue is if there is any symptoms or any of the case definition that we have laid out for Ebola virus disease, they will go definitely into isolation for 21 days. And if there is no symptoms, of course, we go into quarantine also for 21 days. I think this needs to be strictly followed. As such, we have had some suspect cases coming in from Kerala, also from some of the other states, but all have turned out to be negative so far. So I think on the India context, definitely IPC is a key issue that we need to keep for the health facilities, and I think the at least the training for IPC, how to wear a gown or how to wear this kind of setup, especially when it's needed. I think the training is important, which we need to do that. And I remember in 2015 or 16, when the first Ebola outbreak came in, we did training of trainers for Ebola in entire India, especially for the airport health officers, state surveillance officers, district surveillance officers, and some of the hospital key hospital staffs. So I think that concept should be there. Maybe we need some sort of a retraining, especially what this is about, and focus on some of the issues, especially the specimen collection, transportation, infection prevention and control. So all these would be a key component for the training, which may need a refresher at some point of time. That's
Thank you,
from the
sir.
India perspective.
Yeah, thank you, sir. It's really, really nice. And what we found in a ground level is that the infection prevention control remains one of the key cornerstone, especially when there is any outbreak of sort of in the initial time period. And that is something you also highlighted. Thank you, sir. We will take more questions at the end of the session from the chat. So now we will also move that once we hear that, we also have with us Dr. Amitabh Sharkar, who is a public health physician and associate professor of community medicine, and our ex-colleague as a surveillance medical officer with 20 years of exposure. And he has also served internationally in Sierra Leone and Nigeria, supporting Ebola control and interruption of the WPV transmission. So we would like to hear from him his real-time experience about this, and that would be something interesting to hear from him. Over to Dr. Amitabh Sharkar.
Is my presentation visible? Hello?
Please put in slideshow.
Sir,
Yes,
put it
yes.
in slideshow, sir.
Yes, yes. Now it is in slideshow view. Is it okay now? Is it okay now?
No, sir, not in slide, sir.
Yes, now it's okay. Now it's okay.
Okay. So,
Yeah, okay.
good evening to all, and I'll speak from a different perspective. Actually, I had the opportunity to fight Ebola as a field epidemiologist in the largest Ebola outbreak in Sierra Leone, actually. So, whatever I'll speak, I'll speak about what I witnessed there, how we intervened, and how the lessons can be implemented in future pandemics also in India. The same applied to other outbreaks also. So already Dr. Pavana Murthy sir has discussed the details about the context and challenges and the measures of recent outbreak at DRC Congo. So if we look at the both outbreak, actually that Sierra Leone outbreak was explosive, multi-country spread across Guinea, Sierra Leone, and Liberia. And it also reached Europe, USA, Mali, and Nigeria. In contrast, it is now this current outbreak in DRC Congo is concentrated in DRC, cross-border spread to Uganda, and one case reported in France. The context and challenges, somewhere similar and somewhere it is different. In Sierra Leone, it was a very weak health system, delayed recognition, poor community trust, high mobility, and the DRC Congo, it is conflict, humanitarian crisis, insecurity, displaced mobile population, densely populated zones, access barriers. And Sierra Leone outbreak actually mobilized, massive international mobilization was done actually to control the outbreak. So what we can see is the pathogen is old, but the context continuously evolves and modern strategies are incomplete without the operational efficiencies of field epidemiology. So when we entered the Sierra Leone, country, actually we entered in a totally collapsed systems. The country was just recovering from ethnic war, and there is burden of cases already more than 14,000 and 4,000 deaths. And I was assigned as a global search epidemiologist, and I was deployed to high-risk districts in Koinadugu and Tongpoli. There are porous international borders, shared ethnic tribes, deep-seated community denials. And most importantly, the health workers there faced nearly 100% higher relative risk of infection due to lack of basic infection prevention and control. And when we reached there are already 295 health workers who are affected and 225 died, resulting loss of 7% health workers, 7% manpower, health manpowers. And it affected that health system. The virus actually originated from the outbreak already originated from the Melinado village from Guinea in December 2013. And from there, it spread into the Kisi tribal area. It is actually in the Republic of Guinea, a triangular spot between the Sierra Leone, Guinea, and Liberia, actually. And there is frequent migration between these three countries among the tribes. And it is the amplifier. It silently spread through the migratory routes to other countries. And for a long time, it remains undetected because they never guessed about that. We had the global search from different countries of 500 public health specialists. We had 29 we were from India and Sierra Leone and Liberia. And our mandate was clear: move from reactive panic to data-driven field operation and regain community trust. And our TOR was develop a rapid alert and response system, develop a high-quality data analysis and laboratory setting, and integrate response through strategic planning and on-ground mentoring. So what the reality I faced? When we reached there, we saw there deep community resistance, fear, and they were hiding the cases. They were actually avoiding the Ebola treatment centers. And they are rampant secret traditional burial rituals, which was involved washing the deceased, and it drove up to 80% of the transmission chain in many regions. In Koinadugu, I calculated that only 18% of the reports were sick alerts, and the vast majorities, actually, they were the death alerts. If you see the epidemic curve of the three countries from starting of the outbreak to the end of the outbreak, we can see that outbreak started at Republic of Guinea, then it spread to Liberia and Sierra Leone, and the maximum case actually occurred between the from the middle of the 2014 to the gradual rise up to January, and from in the end of the January it started declining, and there was rapid decline after the July 2015, and outbreak was declared ended in November 2015. So actually what we did as a field epidemiologist in the field. So according to our mandate, we launched the active search for alert program as a part of the community event-based surveillance program. What we did, we targeted the silent chiefdoms. We drove up the seek alerts to trigger rapid RRT deployments. We trained the health volunteers, for the alert system, and also we trained around more than 1,000 health volunteers we trained, and also we trained some surveillance officers. These surveillance officers, they are actually my team. They are actually conducting the case investigation and contact tracing in the field. I was supervising and mentoring them, and I was with them as guiding them. So that was one part, active case search. And most important part is the contact tracing. Our mandate was like this, that if you miss 100% cases should be from your contact. If you miss one case from the contact list, that means you miss the transmission chain. And number two, that was a really very hard task for us, data harmonization. So we had data from the case investigation, laboratory investigation, follow-up, contract tracing, but everything was isolated. And there was data mismatch, many missing data, unknown cases were rising up, unknown lab results were rising up. So we need to data triangulation. So we epidemiologists together did that data triangulation part. And as a result, the unknown lab result dropped from 20% to just 6% in under 1 month. As a step 3, we started the survivor tracking. That national team, Sierra Leone national team, developed a 90-day tracking templates for the Ebola survivors. And we captured information on the ongoing health movement, social history, and monitored the latent risk. When we started there, we even didn't know that actually for a long term, semen can be a source of the transmission. We later identified that it can be for a long time. So for a long time, we had to follow up them. And number 4, cross-border evaluation, cross-border surveillance. If there's a porous border of Guinea, so we revived that high-risk migrations from the recent transmission hotspot, and we strengthen the screening program and the active search alert program. The most importantly, we had to fight the community distrust, actually. We had the top-down enforcement, from the community top-down enforcement to community-led response. From the militarized condoms, we actually engaged the paramount chiefs. And from the Ebola kill messages to early treatment saves life. There is fear and hidden cases and avoidance of treatment centers. So WHO developed a safe and dignified burial protocols, and localized community bylaws were implemented instead of the government rules. These are some of the field evidence for the trust building and collaboration. Actually, we moved together with the social mobilization team in different chiefdoms, and we tried to integrate the local, tribal, and religious leaderships into the surveillance networks. So what lessons actually we learned? So challenge was top-down restriction. So when local leader designed the community action plans, it started reducing. There was over-reliance on centralized treatment unit. So we shifted, though it was shifted to small community integrated care centers. There absence of point-of-care diagnostic. So there was international funding for investment in rapid testing and early warning. Health workers' safety was ignored. But later, PPE, IPC gaps were reduced and the standardized training and supply chains were maintained. Most importantly, biosurveillance, that was enhanced for early spillover detection. Regarding India risk, now the crossroads. India has other vulnerabilities as well. Some of the similar to West Africa's, there is mobility, there is migratory population, deeply rooted cultures. Most importantly, there is massive transit corridors, high genetic interference, risk of Nipah avian influenza, decentralized state health systems require coordination, hyperdense urban, peri-urban hubs. So actually, India's though vulnerability actually more or less similar, and actually we have to remain vigilant and continue our surveillance. So immediate risk is low, but the vulnerability to imported cases via international travel and trade is substantial. We must apply these lessons proactively. Three things: surveillance integration, health facility readiness, and risk communication. We have a robust program, IDSP, Integrated Disease Surveillance Program, and they are very much focused for transitioning from the passive reporting to the active searching for the unusual clusters. And One Health integration has been given due importance. The key principle is to act on the suspicion early. Confirmation should refine the response, not delay the first line control actions. There is role of the digital networks, and we have artificial intelligence. Yes, they are powerful accelerators. Digital network can do many things, real-time surveillance, and it is doing also real-time surveillance, case line listing, contact follow-up, event-based intelligence, cross-border information sharing. Artificial intelligence can do the outbreak forecasting, anomaly detection, triad support, resource allocation, but they cannot do the three things. Number one, field epidemiology. Number two, laboratory confirmation. And number three, commodity trusting. We should remember that pandemic preparedness, it's a living system. It's an ongoing preparedness. And it is not only for Ebola, it is for the future pandemic also. So it's a good investment for sustaining effort, financing, and cooperation. It becomes our collective shield against tomorrow's unknown. The cost of managing an outbreak is always greater than the cost of meeting it before it scales. So three things we have to remember. Field capacities remain the shield. Vaccine supplements, but active surveillance and contact tracing can stop the spread. Number two, trust precedes treatment. Community communication network should be established and maintained before the outbreak occurs, during the non-outbreak period. And number three, we have to be proactive, overreactive, not overreactive. A weak link anywhere in the chain can have devastating effect. We learned that, so we should remain vigilant. Thank you.
Thank you, Dr. Shakar. I think that's really, really engaging, and you not only give an overall view, but your also real-time experience of such a massive scale. So that was really helpful. I would just like to interact a few of the things out of here. So when you were there, so you must be facing that there were population movement or cross-border movement or independent spillovers. So what was your experience that how those population movement or cross-border movement actually affected the disease transmission or population transmission?
Actually, that was one of the major reason for the outbreaks and its impact, because there is a movement from that Kisi River area, that Kisi belt, to all the rest of the two countries, Sierra Leone and Liberia, and the borders were porous, and the trade for the trade, fair, and for their cultural practices like funeral, because they have relatives in all three countries. We have relatives, so they were moving. So we had to revive the barrier at those points. We had to identify all the porous borders. We had to make a barrier there, one for the early screening, rapid detection, and isolation. And for that, we took the help of the local chiefdoms, the religious leaders, and the informal leaders, formal and informal leaders. So with their help, we could interrupt the transmission.
My next question is another like understanding the real challenges. So whenever we see this type of anything, the immediate is what I asked the previous speaker is the infection prevention control strategies. And also what we see here also is an overwhelming bed occupancy. So in a health situation where there is an overcrowding, where there is an bed occupancy more than 100%, along with, you say, the funeral practices, all those are disrupted. So what was the situation, and what was the role as a public health expert in mitigating those?
Initially, that was overwhelming. because most of the Ebola treatment centers, what I saw there is actually already the beds were occupied, patients died, but later it was decentralized, earlier screening, and actually when they earliest reporters they earlier started reporting to the Ebola detection center and thereafter treatment center after the intervention of the paramount chiefs. So actually the number uh, reduced. And when we started regaining the community trust, the overall pressure to the Ebola treatment centers also came that reduced. So initially, when there is 80% actually the case fatality rate when we went there, and it came down to around 30%. Because if we start immediate care, supportive care, there is no specific treatment. If we start immediate and supportive care at the initial phase of the disease, we can reduce the mortality. That was our experience.
Really thankful. I mean, that is very good. And so I'll just let me look if any questions in the chat. So there is one last question I will take as we are in. Could you share one instance how community trust was built in the prolonged outbreaks like the one in 2013-15?
Yes, I can give you a very good, sorry, I can give you a very good example. In front, to gain the community trust, number one, we actually, along with the social mobilization team, we went to the each chiefdoms. We asked the permission of the paramount chiefs. They selected the health volunteers who will report the alerts. Number one. Number two, in front of a large Ebola treatment center near Freetown in the western districts, I saw there is a display of the survivors' foot handprint. Actually, they requested all the survivors. Actually, medical director of that Ebola treatment unit, they requested all the survivors to give their handprint over there after discharge. As the time goes by, when the number of handprints increased, so actually people's faith also started increasing. So there are different techniques actually that was applied in that outbreak and became successful.
Thank you so much. I think these are the real examples of the field, and thank you for bringing out this. And we would like to hear from both of you, and would have to continue, but it's everything has to bring an end and because of paucity of time as we are heading close. So I would now like to hand over the session to Professor Aditi Aikad for closing. Over to you. Thank you.
Thank you so much, Dr. Preetham, and our profuse thanks once again to our very eminent speakers of the day, Dr. Pavana Murthy and Dr. Amitav Sarkar, for sharing such wonderfully, in such elaborate manner, all details regarding the current scenario, regarding the hard-won lessons. That last one example, Dr. Sarkar, it was genuinely very inspiring. And Dr. Murthy, it has been really enlightening to know how everything is unraveling in this scenario. And Dr. Preetham, thanks so much for moderating the session so wonderfully. From behalf of IAPSM West Bengal Chapter, we also like to thank our National Secretary General, Dr. Manish Singh, our President National, Dr. Otul Katwal, sir, our National President-elect, Dr. Pradeep Kumar, sir, our State President, Dr. Shukumar Bishoi, sir, and all the Executive Committee members of IAPSM West Bengal Chapter, A special note of thanks for the webinar subcommittee of IAPSM West Bengal Chapter, who have put in a lot of hard work. The smooth implementation that you saw today was because of that fantastic teamwork. A special word of praise for Dr. Ankush Banerjee for providing the excellent tech support from our end, and Ms. Sarika from the end of National IAPSM. We are deeply thankful to each one of you for making this evening so memorable in this inaugural webinar of this venture of ours. As you can see in the screen, IAPSM West Bengal Chapter dreams and aspires to take you through many more such enlightening webinars in the days to come. We have several tracks in mind that involves the public health, the future projected pathways, the innovations, the digitalizations, and more. And our very next webinar to follow will be something on that innovative pathway, where we will unfold occupational health phone art, the role of IoT, LL, and machine learning in occupational health. And it will also be dealt with someone globally known for that. So with that, thank you so much once again to our eminent speakers, our moderator, for graciously accepting our invitation and making our evening so special. And to the national body and to each one of you for choosing to spend your evening learning with all of us. Thanks once again. And now we'll call it a close. Thank you so much.